Okay, I think we're moving on to our last session over here, which is going to be on, we're going to be talking about kind of other complications and concerns of adults with neurofibromatosis type 1. And we have Dr. Carlos Romo joining us and Dr. Anna Piotrowski. I hope I'm not massacring your name, but
that's great.
Yeah. So I'll let you guys introduce yourself a little bit more, but I will say that Dr. Romo is joining us. He's assistant professor of neurology, oncology, and medicine, and director of clinical research for the Neurofibromatosis Therapeutic Acceleration Program that many of us know as NTAP at Johns Hopkins University. And then we have Dr. Anna Piotrowski, who's a neuro-oncologist and director of the Neurofibromatosis Center at Memorial Sloan Kettering Cancer Center in New York. So I will let you take it away. I'm not sure who is starting or presenting. You guys have something going on together, so I'm going to mute myself and let you guys go. All right, thank you.
Sounds good. Can you hear us, everyone? Diana? Perfect. So thank you again, Diana, for the invitation and especially for organizing this event. And I think it's very important for us to stay informed and know who's out there available to help our patients with NF1. So as Diana said, I work at Johns Hopkins here in Baltimore, and Dr. Piotrowski is joining me. She is also a neuro-oncologist like I am, and also treats patients with NF1, but in New York at MSK, Memorial Sloan Kettering. And we thought that we would do not a talk, we're just presenting slides, but actually make it a little bit more interactive. And so what I thought we would do is to present a case that I made up, and from that case kind of ask questions about what we would typically do in the case of adults. We won't talk about children and focus more on the adult population. Dr. Piotrowski will ask me questions. I will ask her questions about what her practice is and what the guidelines typically suggest and what the limitations of those guidelines are. But to start, I just want to give a quick disclosure. We're just giving a summary of the recommendations in people with NF1. This is not meant to be a comprehensive tool to understand or diagnose anyone. And everything we said is a general sense of what we typically would do with adults with NF1, but it should not substitute medical advice from a professional. We don't have financial disclosures to report. We will be chatting about some clinical trials that either Dr. Piotrowski or myself are involved in, and we're happy to answer any questions. So to start with, we wanted to talk about this patient, Ms. Jones, who is 35 years old. She was diagnosed with NF1 when she was a young child, maybe when she was 1 or 2 years old, because she had many cafe au lait macules, or those darker spots in her skin, and she was told she had NF1, but she had never been seen by an NF1 team, and she just sees her primary care doctor every other year or so because she's relatively healthy, but she was referred to a neurofibromatosis center, and she's now seeing us, and she has at least 3 concerns that she wants to chat with us about and wants to know and learn more about NF1 and other considerations that she should have. So she says that she has 3 concerns. One of them is that she has 2 children. One is 2 years old, and the other one is just 3-month-old. And she wants to know if they are at risk of having NF1 or not, and what that risk might be. She also has some skin bumps that she doesn't know what they are, and sometimes they itch and sometimes they hurt. And also she has a mass in her thigh that has been a little bit painful and maybe growing a little bit. And so she wants to talk about those 3 things and anything else we could say about NF1 she's interested in knowing about. So Dr. Piotrowski, what are your first impressions when you encounter a patient who's diagnosed with NF1 but has never been seen by someone who understands NF1?
This is a very typical patient for me, Dr. Romo. Most of the patients who we meet for the first time are in this typical age range, and they have not had regular comprehensive care. They have not had access to a specialist before coming to the NF Center. And the unfortunate thing is they might have actually had misdiagnosis prior to meeting us.
That's absolutely true. So I thought we maybe would start by addressing her concerns. There's 3 specific concerns that she has, and then we go to talk about other things that we as NF specialists would think about and worry about too. So risk of passing on NF1 to her kids, what would you tell this patient, Dr. Piotrowski?
So we had a great overview on NF earlier today, and we would tell the patients that this is an autosomal dominant disease. So she has about a 50-50 chance of passing it on to her offspring.
Right, I agree. And then I will chat a little bit later about genetic testing, or maybe I can mention it right now. Some people opt for genetic testing. As you might have heard earlier today, the diagnosis of NF1 does not require that genetic testing is done. The diagnosis can be made solely on a physical examination. So doctors would take a look at your skin and ask questions about your history. Maybe we'll review imaging studies if you had them done before, and try to make that, as Dr. Piotrowski was mentioning, some people are misdiagnosed as having NF1 when they in fact have either schwannomatosis, NF2, Leach's syndrome, something else. Or maybe I've had patients who are referred to our clinic because they have a single cafe au lait macule or a single cutaneous neurofibroma, but nothing else. And the question is whether they have neurofibromatosis or not. So that's a very typical question. And one of our tasks is to confirm or rule out NF1 and make sure that there's nothing else. When the diagnosis is not very clear, that's when we sometimes do genetic testing. There are other instances in which genetic testing is helpful, especially when you're trying to do prenatal testing before a baby's born, or when you want to test your kids who don't have many manifestations yet at all, and you want to learn about their diagnosis, whether they have genetic NF1 mutations or not, or pathogenic variants as they're called now. So there are instances where genetic testing is valuable, and we typically refer our patients to a genetic counselor who can help them understand what the test would entail, the potential results of the test, and their implications. But yeah, absolutely. With each pregnancy, the risk of having NF1 is 50-50%, as Dr. Piotrowski was mentioning. Another one of her concerns was that she has these bumps in her skin, and she doesn't know exactly what they are. She thinks they might be tumors, and sometimes they itch, sometimes they hurt, especially if she has accidental trauma where she bumps some of these tumors and they cause pain. So, Dr. Piotrowski, what's your approach to this question about neurofibromas?
We talked a little bit about surgical options for cutaneous neurofibromas. Dr. Lee gave us a pretty good overview, and we also heard about the Hopkins-Stanford collaboration, which is amazing work. And we know that cutaneous neurofibromas are the most common and most bothersome of all the NF disease manifestations. So nearly every patient that I meet for the first time in all of our follow-ups do want to talk about their skin symptoms.
And one of the concerns that I frequently get from patients is whether they should be concerned about them because they notice new ones over time, and some of them are getting bigger. Some of them are changing color where they look a little bit more red or a little bit darker. Are we concerned about them becoming cancer, or do we need to remove them if they're not causing symptoms?
As far as we know, there is no evidence of malignant transformation from a cutaneous neurofibroma into a malignant tumor. But as far as quality of life and patients' emotions and their well-being, we do like to talk about both surgical and possibly non-surgical options for the removal if they're causing tremendous discomfort, pruritus, and bleeding.
Right. And pruritus, or the itchiness, is relatively common, and it doesn't itch in one particular neurofibroma. In most cases, I've seen patients itch on multiple sites. And sometimes we even see this generalized itching where really it's almost their entire body that itches periodically. And some patients tell us that it particularly worsens when it's cold or when it's warm. It varies from patient to patient. And there are medications that are used for itchiness from allergic reactions or eczema, like Benadryl, but those tend not to be very effective in the itchiness that's caused by NF. And so medications like maybe gabapentin, which is actually an anti-seizure medication that we very frequently use for pain control too, and we'll talk about that, can help patients with NF1 that have pruritus or itchiness from cutaneous neurofibromas. One of the other things that I wanted to mention about cutaneous neurofibromas is that we don't understand their natural history very well. There are some studies, and by natural history, what I mean is their evolution. Typically, but not always, we see that very young kids don't have too many cutaneous neurofibromas, sometimes none at all. But when they become teenagers and their puberty, they start developing neurofibromas. And we typically think about neurofibromas in the skin and the ones beneath the skin, just beneath the skin, that we call subcutaneous neurofibromas, as benign tumors that can continue to increase in both size and in number. And frequently we think about them achieving a plateau where we don't see too much growth by age 40. But it is possible to get new neurofibromas, unfortunately, past age 40. And so one of the studies that I wanted to talk to you about today is a research study at Johns Hopkins, where I work, where we are monitoring patients with neurofibromatosis type 1 of all ages. The youngest of our patients is 1 year old, and the older patient is 63, I believe. But we take any patients and I'll talk to you a little bit more about that research study, but we're trying to understand better how these benign tumors evolve over time. And I hate using the word benign exactly for what Dr. Piotrowski was saying, that although they're not cancer, they're really not benign. They really cause a lot of problems, pain and disfigurement, itchiness, low self-esteem, things like that are real problems. Okay, great. And I don't know, Diana, could I ask you for help if there's any questions on the chat box to let us know, and feel free to interrupt and ask questions. We'd like this to be
I don't see any right now, but I'd be very happy, even though I don't have NF, until other people jump in here. I'd be very happy to pretend I'm a patient and go, oh, what about? So I'm here and I'm thinking, great, I have all these neurofibromas and you tell me I can get them removed. Well, how am I supposed to do that? Where am I supposed to go?
Yeah, those are great questions. Dr. Piotrowski, I don't know if you want to take that one. I'm happy to.
There are a few dermatologists who are interested particularly in NF, but there aren't any, I'd say, proven methods that we have for the best way. The interventions that we have to remove cutaneous neurofibromas include surgical options, which often leaves a scar. They can be ablated either by laser or carbon dioxide, and patients might be able to have many tumors treated at once, and they can be very satisfied with the outcome, but eventually they do occur. We are actually opening a trial here for a topical gel for cutaneous neurofibromas. So that might be a little bit more accessible for patients to try doing a gel at home.
Is that the one that they're doing somewhat nationwide with the Inflection?
Yes.
I think we do want to share that. I think a lot of people would probably be interested in that. I don't know if there's a link for it, and I maybe we'll try to get more information on that. But I know this is a struggle because we listened to Dr. Lulay gave us a lot of the ways that you can remove these, and I know that people still just they struggle. I can tell you personally from my husband and my daughter now that you can go to some dermatologists and they do a great job of removing them. You just make sure they remove the whole thing, and there are plastic surgeons that do a great job of removing them. But I can tell you that people they'll go to a plastic surgeon and they'll say, oh no, just leave it alone, or a dermatologist who will say, oh, we'll just shave them off. So I don't know what, I mean, personally, I'm not the doctor, so my advice is to people just make sure they remove the whole thing. Right? I mean, is that what you would say?
Right, right. So shaving them off might not remove the entire neurofibroma. And as Dr. Piotrowski was saying, even if you do remove the entire neurofibroma, there is a potential chance that they would come back. But in a lot of cases, if they're surgically removed, or if they do electrodesiccation or a laser form of treatment, the possibility of them coming back is kind of low if it's done appropriately. And that's dermatologists, plastic surgeons are typically the ones that do those treatments. Maybe some neurologists who treat patients with neurofibromas also can do those treatments.
The plastic surgeons sometimes want perfection, so they're a little more reluctant to do it. And you're not going to have perfection. Sometimes it's just going to be better.
And the indications for removing them, like I said before, it's not because we're concerned about them being cancerous, but because they can hurt, they can bleed, they can get irritated, they can cause itchiness. And a lot of the times patients just don't like how they look. And so having them removed for aesthetic reasons is a valid reason to having them removed. The concern sometimes is that insurance companies will give you a hard time for having them removed if they're asymptomatic, if they don't have any symptoms.
So then my other question is going to be, are all my bumps dermal fibromas, or could some of them be a plexiform, even, that they're just under the skin? I have one in my hand that's sticking up and I'm not sure, is that something I can go get removed and cut out, or is that maybe a little more involved?
I'm happy to take it, Dr. Piotrowski. Do you want to comment on that?
Well, yeah, that's a great question.
I'm playing stump the doctor.
Yeah, so patients with a neurocutaneous syndrome have a tendency to form benign tumors throughout their bodies. And it's possible that a plexiform neurofibroma has caused swelling such that you can palpate it from touching the skin. There are cutaneous and subcutaneous neurofibromas as well. So sometimes we might not be able to tell the difference without an ultrasound.
I say I knew the answers to some of these. I'm just winging them up there. Because I know sometimes they can be, more of a little plexiform or more involved in the nerves. And so people do have to be careful, right, about going to their dermatologist. We do have a couple of things that we have a question that came up here about how does the sun affect neurofibromas while we're talking about those? Is there any evidence that they could cause them to grow more or not?
We don't know. There are a few things that we know can potentially cause them to grow more. I don't know that there's been any strong relationship between sun exposure and growth of the cutaneous neurofibromas. In women who are pregnant during pregnancy, the number of cutaneous neurofibromas in several studies has been shown to increase. So it doesn't mean that it's necessarily going to happen, but in women who get pregnant, the chances are that the number of cutaneous neurofibromas could increase. In women who are taking contraceptives that have estrogen or progesterone, some studies, in some cases, there's a suggestion that those medications or those drugs could increase the number of cutaneous neurofibromas, but other studies showed that there's no increase. So we also don't have a strong relationship between the use of oral contraceptives and the development or increase in the number of cutaneous neurofibromas. Sometimes I do recommend that they don't use hormonal contraceptives, or that they use them, that they use something like an intrauterine device. But again, I've had many patients who are on the oral contraceptives or injectable contraceptives or that are hormone based, and they don't have increase in the number of their neurofibromas.
How do we get more of these answers? I personally, I have children who are 28 and 29. I've been doing this for a long time, and I know it's slow to get the answers.
Yeah.
You need to get more questions than answers.
So one of my last slides for this presentation is really a plea to all of the patients to participate in research as much as they can. Research is not for everyone, and we absolutely respect people who are not interested in doing research. But I really appreciate the courageousness and the real sense of trying to move the field forward of those patients who participate in our studies. So if you wanted to participate in the natural history study of cutaneous neurofibromas that we're currently running here at Hopkins, that is a study that will take all patients of all ages, of all races, and we're trying to learn how, if any, of these factors could affect the growth of neurofibromas. And I'll talk a little bit more about that study and how we are monitoring patients. But we're using this very cool technology where we have a setup of 92 cameras, and we take pictures of the entire body and create a 3D avatar. And we're taking pictures once a year for up to 5 years. And as we're taking those pictures and monitoring the cutaneous neurofibromas, we're asking patients about their quality of life, their symptoms, and also medications, hormones, episodes in their life that might be contributing to how those neurofibromas are acting or not. So by the end of those 5 years of monitoring, we might be able to learn if there are any factors that are causing them to increase, shrink, go away. We don't know, right? So that's exactly what we need to do more research for a lot of these questions to be able to answer them and not just have speculations.
Yeah, and I'm not dumping on you guys about it. I know I've been involved for a long time, and I see how hard it is to move forward. And I think it's just really important for people to participate in research. And we shared the video earlier for the genetic study that people should get involved in too. You do have a lot of questions coming in now, I think, but I don't know, since we talked about fibromas and you brought up with the patient, I don't know if there's any more specific questions about fibromas, maybe. So we're staying on that subject, and maybe we can move on into your patient here.
So I think we answered her question about these bumps that she didn't know what they were. They are possibly cutaneous neurofibromas, but as Diana, you said, and as Dr. Piotrowski was mentioning, it is really important to see someone who knows a little bit about neurofibromatosis, if possible. I know it's very difficult, but if possible, to distinguish between cutaneous neurofibroma, which is completely benign, versus a plexiform neurofibroma, which could or could not be benign. And there are diffuse skin neurofibromas that appear to be plexiforms, but are not plexiforms. And trying to remove those is very challenging because the skin that's affected by neurofibroma does not really heal as well as healthy skin. And so someone who knows those nuances might be able to advise you better about what to do and what kind of studies we needed, whether it's an ultrasound or an MRI or something else.
Okay.
And talking about
taking some of these questions or go on with your patient, or because there's a great question here.
Go for it. What's the question?
It's if you're an adult who has no obvious NF1 issues, how often should you be seen in an NF clinic?
We'll touch more on the details later on, but we do recommend annual surveillance of asymptomatic adults with NF1.
Even in an NF clinic, because I'm always feel like most adults cannot get to an NF clinic because there are very few adult NF clinics. And in all honesty, we were talking about the population that has NF. If you had all of these NF1 adult patients going to an NF clinic, it would be impossible. It would be impossible. So I just wonder if that's really practical or not if you have no symptoms. Personally, I think people need to be educated, very well educated, and have a doctor that's listening to them.
Yeah, it's very difficult. I agree. And one of the things that I hear from our patients is they're just so relieved sometimes that for the first time they're learning from their physicians and not teaching them. NF is a rare condition, relatively rare, and most physicians that are not NF specialists or neuro-oncologists or even neurologists probably have never seen a patient with NF. So when our patients go to them, frequently the patient is more informed about NF than the providers. And so I do recommend that if possible, if at all possible, try to be evaluated here and there by an NF specialist, and we can help you and talk to your providers at home, follow the recommendations for the guidelines of what to look for, even if you don't have too many symptoms. I just saw a patient not too long ago who told me, if it weren't for the MRIs, which show a lot of internal tumors, I probably wouldn't know that I have NF. And unfortunately, that patient, we've had to take 2 tumors out that were very concerning. And
Yes.
so even
Yeah,
if you don't see the skin manifestations, I think periodic evaluations for NF are very important.
it's just it's a struggle because, pragmatically, it's very hard for an adult. I mean, it's close to impossible for most adults to get to an NF clinic. Here in Chicago, here in Boston, in New York, and Washington, D.C., and Baltimore, and, some of these other places, even in LA, yes. And even then it can be hard because it's not in your network or whatever. So it is very hard and not practical for everybody to go. So I think, but it is very scary that people have things that they don't realize are part of NF. We will, I'll share in a minute the care guidelines, because I think that, there was those adult care guidelines that were published, and maybe that's something people can share with their doctors. And I don't think I'm always telling our adults, let's not get mad at these doctors because they don't know NF. They only have a couple patients, so you just have to find somebody that recognizes that maybe they need to learn about it.
Yeah.
Sorry, go on.
No worries. We have a lot to talk about. So those are great
Yeah, let's go.
questions. Yeah, I'll move on to the next concern of our patient, which was that she has a mass in her thigh that was causing her pain. So we've talked about the cutaneous neurofibromas and the subcutaneous neurofibromas, but there are other types of neurofibromas that we call plexiform neurofibromas, or paraspinal neurofibromas are another kind. So in this picture here, A through C, you see a patient's MRI where we can see the spine from the side and a couple of images from the front in the thoracic spine and in the lumbar spine, where we see these tumors here close to the spine. Those are paraspinal neurofibromas, and there's other tumors that can develop in other peripheral nerves, such as in this image here. And if our patient was having pain, and especially if it's associated with something that's growing, if she notices that there's swelling or increasing in the size of an extremity or the neck or the chest or some place in her body, and there's pain that's getting worse, I'd be kind of concerned about that and maybe suggest that we get an MRI. Dr. Piotrowski, how would you approach this patient in particular? Has a mass that she can see, she can touch, maybe it's increased in size over the last couple of years, and it's causing pain here and there.
So this is a very important topic to discuss because NF patients do become accustomed to living with a certain amount of pain and problems associated with their NF. So they may be reluctant to share with us symptoms. We would be concerned about a progressive increase in very severe pain, a change in tumor size, or some of the radiographic features such as nodular enhancement or diffusion restriction, PET avidity, that would make us very suspicious that this has transformed from a plexiform neurofibroma to a malignant peripheral nerve sheath tumor.
Yeah, I agree. I would probably examine this patient. Of course, I think that's a very important part of things, to get a good neurologic examination to evaluate sensory deficits, weakness, problems with coordination, things like that, and to more objectively measure these tumors, as Dr. Piotrowski is suggesting, probably get some imaging studies and rule out signs of concern. So, and as part of what she's mentioning, it's not just the mass, but pain. And Dr. Piotrowski was saying, you were saying, Anna, that patients with NF1 frequently have pain. So how do you go about talking to your patients regarding pain? And frequently, if this was a new patient, she might come in saying that I take 600 milligrams of ibuprofen 2 or 3 times a day because of the pain. And it doesn't really help, but she doesn't have other good options. Tylenol doesn't help much, but she takes it occasionally. So how would you approach this?
History taking is essential at this point. The patient should give us some details about the location and the quality of the pain, some alleviating or exacerbating factors, and the duration as well as the severity. It's important for us to know what type of pain we're talking about, whether it's nociceptive or neuropathic. And the frequency and severity would help us to decide whether the patient could benefit from either a prophylactic or an abortive medication. Prophylactic medications such as anti-seizure medicines or antidepressants can be used regularly, whereas abortive medications such as anti-inflammatories or steroids, rarely opiates, but also muscle relaxants can be helpful. Most of the patients, however, who are young and are dealing with chronic condition might be interested in non-pharmacologic interventions for pain. So in these cases, injections or nerve blocks can be very helpful. We work very closely with our pain management specialists. Acupuncture and exercise, as well as cognitive behavioral therapy, can be very helpful in NF-associated pain, and we do try to leave surgery as a last option. If there is a plexiform neurofibroma that is causing pain and disability, that may be a surgical candidate, but the plexiform neurofibromas can rarely be fully resected, so we would try non-invasive means as well.
Great. Yeah, I agree. Absolutely. So I think your doctor should talk to you about pharmacologic and non-pharmacologic options. And there are several options, and it's frequently very difficult to get the treatment right on your first visit. I think it's a lot of forming a relationship with your doctor and establishing what works best for you, what hasn't worked best for you. In my case, I feel it's always very useful to understand where the patients have been, what they've tried before and has failed, so that I don't try that again. So keeping a good history and good records of, have you tried gabapentin? If so, how many milligrams? What happened? Again, I saw a patient not too long ago who was started on gabapentin, 300 milligrams at bedtime, and after a couple of weeks, they discontinued it because it didn't help. And I don't think the physician that was treating the pain gave the medication a good chance to start acting and really help with the pain. And so, again, chatting with a patient about where they've been, what they've tried before is very important, and understand how much insurance companies would cover of the non-pharmacologic treatments, which is also a struggle. So I think we've addressed her three concerns, but she wants to know more about, is there anything else that I need to be thinking about? And we already answered that question briefly and not comprehensively enough when someone in the chat box mentioned not having many problems or obvious problems with NF. So Dr. Piotrowski, maybe we can talk a little bit about how we think about patients with NF and the risk of malignancies, of cancers. So what can you tell us about that?
We know that NF patients have about 8 to 15-year reduction in their average life expectancy, and this is primarily due to malignancy and cardiovascular risks. So we know about some malignancies that are associated with NF. Most commonly, we talk about MPNST, breast cancer, pheochromocytoma, and gliomas, but there are many other cancers that exist that have recently been discussed as also having higher incidence in the NF population compared to the general population. So now's a great time to talk about, I think, specific tumors as well as our screening for additional cancer risk.
And how do you go about screening, for example, is there a screening recommendation for MPNST?
So we like to follow the whole body MRI for plexiform neurofibroma tumor burden, partly because of the risk of transformation to MPNST. We don't have an accepted MRI versus PET modality, but because there is such a poor prognosis associated with MPNST, we do know that early detection is key.
Right. So I know that whole body MRIs are, the availability of that is very, very limited. even at Johns Hopkins big hospital with many, many different sites, we can only do it at one site. And that's the extent of the entire state of Maryland where we can do whole body MRIs. So I don't typically recommend that patients get whole body MRIs routinely, and most patients don't have access to whole body MRIs to get the staging of their disease burden. But I agree. I think if there's pain, if there are symptoms, so I think the risk factors would be new or growing masses that you can feel or see, rapidly progressive growth, pain, and of course, a history of prior radiation somewhere is something that puts you at a higher risk of developing NPNST. And maybe that area that's hurting, growing, was radiated should be imaged at certain time points. Now, as Dr. Piotrowski was saying, the guidelines are not very specific how often these MRIs need to be done. And if it's MRIs or PET scans, some institutions prefer MRIs, some institutions prefer PET scans. I'll do another shameless plug for another study that we're doing here at Hopkins, where we are obtaining whole body MRIs for our patients once a year to see if they can help us determine the transformation from a benign tumor to a cancerous tumor. Because we think MRIs are helpful, but we don't know a lot yet. So this is an imaging biomarker study that is hoping to get a better understanding how useful these whole body MRIs actually are or not. So that's something that we are trying to learn. What about breast cancer? So this is a 35-year-old woman. Should she be screened for breast cancer? And if so, what is your recommendation?
Yes, I believe that this woman should be screened for breast cancer. Breast cancer occurs more commonly at an earlier age and is associated with worse outcomes in patients with NF compared to the general population. This is a trend that we'll see recur with most NF-associated cancers. And this might be related to the fact that NF patients they poorly tolerate treatment compared to patients without NF. That's another trend that we're trying to understand, but the general population should have a screening mammogram annually starting at the age of 40. But for NF patients, there are some experts who do recommend a mammogram starting at age 30. That's a little bit controversial because there is a risk of false positives and unnecessary biopsies as well as anxiety. But the earlier detection of breast cancer is possible with earlier screening.
Can I ask a question about this? If you do have breast cancer and maybe even other types of cancer, is it treated the same? Can it be more aggressive? Is it seen to be more aggressive more often in people with NF1, or is it just what you had said about poorly tolerating treatment? And when you mean poorly tolerating, do you mean that the treatments don't work as well, or is there just physically they don't tolerate it as well?
The patients who have breast cancer and NF might have been diagnosed later. A couple of possibilities are perhaps there are plexiform neurofibromas or cutaneous neurofibromas that prevent a mass from being detected early on. And if in that case, the breast cancer is detected a little bit later than the general population, that might be a reason why there is a worse outcome. The type of breast cancer that we see in NF1 most commonly is invasive ductal carcinoma, which is the most common type of breast cancer in the general population. So it is the same type of cancer, and the anti-cancer treatments are similar. The chemotherapy agents that are used for NF and non-NF breast cancer patients are similar, but the side effects might be more pronounced in the NF patients.
That's interesting. And I do know one gentleman that I know with NF1 has breast cancer. So I didn't know if that might be a little higher increase for men.
We're still studying whether contralateral breast cancer or breast cancer in men is more or less or the same in NF patients compared to the general population.
So I don't recommend, obviously, men to get mammograms, but I always talk to my male patients, younger male patients, to tell us if they feel any changes in their chest. And again, we don't want to overreact because those changes could be cutaneous neurofibromas or subcutaneous neurofibromas, but we also don't want to miss something that's important. And so in women, I think annual mammograms, and typically I do suggest getting them at age 30, would be important. If a woman has a history that already puts her at a higher risk of breast cancer, like a personal or a family history of breast cancer, or a BRCA2 mutation, which is another mutation that puts women at risk of breast cancer, I would probably suggest maybe even getting MRIs of the breast, which are a little bit more sensitive. They are a little bit better at detecting changes and trying to determine whether those changes are because of neurofibromas or actually because of tumors of the breast gland. Some other controversial recommendations would include a manual breast exam by your primary care provider or your gynecologist once a year, and self breast exams, which I frequently talk to my patients about, knowing their breast well and how to properly do breast exams. It's not just feeling your breast here and there. It's actually, there's a technique of doing that. And so I talk to my patients about how to do that once a month, knowing that there is a higher risk of false positives, as Dr. Piotrowski was saying, and the need for unnecessary biopsies, unfortunately. And I think that in the previous session, someone was asking about pilocytogastrocytomas in adults. I don't know if that person is still here or not. I'll briefly mention that an answer to that question. So pilocytogastrocytomas are tumors that arise in the central nervous system, so either the brainstem, cerebellum, or spinal cord. They are typically considered to be benign tumors. Again, I don't like using the word benign, but they're typically considered benign tumors when they happen in people without NF1. So people without NF1 can develop pilocytogastrocytomas. When they happen in people with NF1, those pilocytogastrocytomas sometimes do not behave as benign as we see them in the people without NF1. And so even in NF1, I do get concerned when I see someone with a pilocytogastrocytoma, and I tend to monitor them more closely and tend to be a little bit more aggressive in its treatment than in people without NF1. And again, that's something that we're trying to study. Dr. Piotrowski and I are currently working on a study to evaluate adults and non-optic pathway glioma. So that would include pilocytogastrocytomas. And unfortunately, we don't know much about how they behave. And we see that they're rare tumors, fortunately, but they do happen more frequently in people with NF1 than those without NF1. So we're trying to understand them better. So I think that's it for malignancy. And again, we're happy to take questions, but I would also talk to patients about cardiovascular complications and recommendations about how to screen and treat those. So Dr. Piotrowski, again, how do you talk to your patients about this?
NF can affect the blood vessels. They can be the small or medium or large vessels and can cause problems such as hypertension, renal artery stenosis, or pheochromocytoma. This is rare, and it's important to keep in mind that common things are still common in NF patients. So essential hypertension is usually the reason why an adult has an elevated blood pressure, but it is important to have a high clinical suspicion for other causes such as renal artery stenosis or pheochromocytoma.
And do you typically, so renal artery stenosis would be when the blood vessels going to the kidneys decrease in caliber, they are smaller. Do you typically order imaging or do blood tests, or how do you typically go about this? Do you do it in every patient with high blood pressure?
That's a good question. Of the patients who have high blood pressure, not all of them have renal artery stenosis, and not all of them have pheochromocytoma. I think pheochromocytoma is a little bit more distinct because the hypertension is associated with episodic headache, palpitations, and sweating. But I think renal artery stenosis is important as a screening tool as well through imaging.
Right. So I agree with you. I typically don't do imaging studies on everyone who has high blood pressure, but I'm a little bit more suspicious about renal artery stenosis in younger patients. So if I see a patient that's they're low 40s, 30s, especially 20s, where typically someone shouldn't have high blood pressure, then I might be more inclined to listen to their belly to see if there's any whooshing sounds that would suggest artery stenosis. That's a very non-sensitive way of detecting this. So I would probably follow up with imaging by doing an MRA, which stands for MR angiogram, magnetic resonance angiogram, and that will give me a picture of their blood vessels and tell me whether they are of normal caliber, normal size or not. And for pheochromocytomas, we can do blood tests and urine tests to measure. So pheochromocytomas are tumors that can be both benign or malignant. They're more commonly benign tumors, but they can start producing hormones that increase your blood pressure. And those hormones are not always elevated. Sometimes they're a little bit lower. And that's why, Dr. Piotrowski, you were mentioning sometimes people have headaches, sweating, problems with palpitations. And that's typically when the hormone levels are a little bit higher. And so we sometimes measure the levels of those hormones in urine for 24 hours. So we collect the urine of 24 hours and measure something called metanephrines and catecholamines. And again, that's something that you don't need an NF specialist for. Primary care doctors, internal medicine physicians know about pheochromocytomas, cardiologists know about pheochromocytomas, and they would be able to order these tests. They're not exotic tests. They're done in most labs. Okay, great.
I just want to apologize to one of our attendees who reminded us we wanted to touch briefly on GIST on the previous slide, Dr. Romo.
Okay. Yeah.
So we had discussed some of the malignancies that are most frequently associated with NF, but gastrointestinal stromal tumor is very commonly seen in our patient population and in a higher incidence in NF patients compared to non-NF. We know that there is actually a different molecular driver for GIST in NF1 compared to the general population. And because it is rare, registries are really important for us to understand patients with these rare diseases. So we have some data from the Surveillance Epidemiology and End Results, or SEER database, that tells us that in addition to the MPNST and the breast cancer and the pheochromocytoma, gliomas, and GIST that we frequently think about, there is in pediatrics a condition called JMML. Pediatric patients may also develop rhabdomyosarcoma or a malignant fibrous histiocytoma, which is a bone cancer. Thyroid cancer is possible, but we're adding to the list melanoma, ALL, which is a type of leukemia, ovarian cancer, prostate cancer, and meningioma. So our motto is, if you feel something, say something. We have established guidelines for screening earlier than the general population for malignancies such as breast cancer, and neuroimaging is part of standard care for NF. But if NF patients develop symptoms anywhere in the body, it's important for us to hear about them. And our fundamental belief is that there's no such thing as too many patient calls. We like you to write down your questions. We want to hear about all symptoms, big or small, because there's a team of healthcare providers who are ready to assist. And the reason for frequent monitoring is to detect cancers early when more treatment options are available.
Can I ask that attendee if they had a more specific question about the GIST? I don't know if they'll answer here, but I don't know if there was something. Our treatment's the same or different for NF GIST patients, I guess, as somebody doesn't have NF.
The treatment options are similar, but the molecular drivers are different, and that I think is going to fuel our future targeted therapy trials.
Now, GIST also, because of the molecular drivers being different, GIST also in people with NF1 tends to behave a little bit different. And in this case, actually, in people with NF1, it tends to behave less aggressive than in people without NF1. So sometimes, many times, NF1 patients with GIST do not require treatment. We diagnose it and we monitor it. And that might be the end of that. A lot of patients with GIST do not require significant surgeries or chemotherapy or radiation. That's not always the case. And again, that's when you really want someone to understands GIST to help out and make recommendations. Sometimes chemotherapy and other treatments are necessary, but it tends to be a little bit less aggressive in people with NF1. And if they do have any other specific questions about GIST that we haven't answered, we're happy to try to answer them. Okay, moving on to another consideration, which is bone health. Dr. Piotrowski, what would you say to this woman? She's 35, she's healthy, she's active. Does she need to be worried about bone health?
I recommend that all NF1 patients have their vitamin D level checked. We know that there's an association with NF and osteoporosis, and most of the experts would agree that a supplement is indicated if the level is low. We can also talk about Dexa scans as well, Dr. Romo. So recommendations for bone scans are based on age and hormonal status and sex, as well as other risk factors. And we would like to keep an eye on all of the bony complications, including osteoporosis and scoliosis as well for patients with NF.
And I think a bunch of our patients think about scoliosis as probably a problem of childhood or adolescence, but there are a few adults who have worsening of their scoliosis or develop new scoliosis as young adults. And so we'd like to monitor those patients and make recommendations as needed. But for sure, scoliosis is more common in people with NF1. Good.
Question.
What about?
I have a quick question.
Yeah.
Taking I don't know what medicine it is, but I know there's a drug for osteoporosis. If you're young and you have NF and you have bone issues that are, I guess, kind of osteoporosis, do they know if those drugs help?
There are many treatment options for people with osteoporosis, NF1 or no NF1 osteoporosis. Maybe you're referring to alendronate or zoledronic acid or those kinds of medications, which are typically either injected on a periodic basis, infused, and sometimes orally administered. Those medications can potentially help with people with NF1. There is a suggestion in some studies where the benefit of those medications in NF1 might be a little bit lower than in people without NF1, but it's still something that we use frequently. And there are bone health clinics or bone metabolism clinics in some centers. And here at Hopkins, we typically, when we have problems in the NF clinic, we refer them to the bone metabolism and clinic, and they're able to help us in diagnosing, treating these patients as well. But I mean, you don't need that amount of specialization. I think most primary care doctors are comfortable screening for osteoporosis. It might take a little bit of education from your part and telling them that you need to be screened maybe a little bit earlier than the general population, but it is something that can be done by primary care doctors. So another thing that we think about when we are chatting with our patients are neurocognitive and psychiatric concerns. So again, Dr. Piotrowski, what are your typical recommendations for a patient like this woman who has not reported any problems, but is maybe not aware that she should be talking to you about them?
Screening for these issues is very important. The full neurologic exam should include some basic memory testing as well as attention. But it is important to screen every patient for depression at every single visit, because if the patient doesn't feel depressed at the moment, it is important to continue to ask and find out whether the patient has had a loss of energy or interest or appetite, or if they're having trouble sleeping, because there's a higher association of depression in NF patients. Attention disorders can affect many things, well-being as well as employment for adults. So it's important to make a diagnosis if that is something that we can help. There's an entire spectrum of cognitive impairment, from a mild visual-spatial trouble, all the way to trouble with executive functioning. So there's a lot of things to consider as far as the severity of the disease manifestations in NF.
Thank you. Dan, I don't know if you have any questions or if our chat box has any questions about neurocognitive problems and psychiatric concerns. Again, a lot of the neurocognitive concerns are something that a lot of patients think more about affecting children and not too much the adults, but it is something that frequently is problematic, and it's more common in people with NF1.
I see a question, Dr. Romo. There's any thoughts about insomnia related to NF mechanisms and treatment?
Well, mechanisms is difficult. I don't think we understand the mechanism, and people with NF1 are not only affected by this list. Again, this is not a comprehensive list of problems that people with NF1 experience. People with NF1 also have an increased risk of headaches. They have an increased risk of epilepsy or seizures. They have a slightly higher risk of stroke. Both the one where there's a blood clot and oxygen doesn't go to the brain, and also the kind of stroke where there's a bleed in the brain are increased in people with NF1. And insomnia and other sleep disorders are also something that we see frequently in people with NF1. So again, because sleep is such a complex function of our brain, I typically talk to our patients and try to understand what's causing the sleeping problem and the insomnia. Is it the anxiety that's feeding, or the depression that's feeding the sleep problems? Do they have other health conditions like anemia and iron deficiency could cause restless leg syndrome? Do they have any thyroid function problems that could be contributing to their sleep issues? I always ask about, like Dr. Piotrowski was saying earlier, common things are common even in patients with NF1. And a lot of our patients have poor sleep hygiene, where they're sleeping on conditions where sleep, restorative sleep, or sleep that actually helps you rest, is not appropriately achieved. And so I chat about those things with them. And again, this is not something that you need an NF specialist to talk about. Most PCPs, primary care providers, would be able to talk to you about sleep hygiene and make some general recommendations. If you think the care that you're getting or the care is not optimal, you can always be referred to a sleep medicine physician. And those guys are a little bit more common than NF specialists. There are sleep medicine doctors in most states and in larger cities. And so doing a sleep study might be recommended for some patients to rule out obstructive sleep apnea and other conditions. But yes, as a general term, I think it's always a good idea for anyone, NF1 or not NF1, to go over the list of what sleep hygiene recommendations are and try to see if any of them apply to you and you can use them. There are over-the-counter supplements. Some of them are beneficial. Some of them are not great to take routinely. So I would try and recommend to stay away from Benadryl and other medications like that. To be taking Benadryl chronically is not great for memory and things like that, and it might affect your balance. And so I don't think Benadryl is a good option, but melatonin might be a safer option, an alternative. But again, speaking with a provider to specifically talk to you about why you're having insomnia and what other ways they can help you would be better.
I like this. Common things are still common in people with NF, but it also seems like common things are also more common in people with NF. But I think the point is that they're still treated the same way.
Unfortunately, I think that's the case.
Yeah.
Okay.
Dr. Romo, do you see ADHD showing up later? One of our attendees says they never had issues as a child, but now seem to be developing issues which include anxiety.
Well, ADHD is more common in kids. It can, of course, cause problems in adulthood. And there are adults who are diagnosed with ADHD that have had symptoms for many years. And so it is something that can be diagnosed in adulthood and can still bother people and affect their ability to work and interact with others. Now, again, speaking with a medical professional about your specific case would be important, because anxiety by itself can also cause attention problems and difficulty focusing and problems with sleep. So anxiety and depression, which are common in the general population, but even more in adults with NF1, can cause problems with memory for sure, and attention for sure, just because of depression and just because of the anxiety. So trying to understand what's causing your problems with attention is very important, because the treatment for ADHD is different than the treatment for anxiety or depression. And sometimes we see both conditions together, that you have ADHD and some degree of anxiety and or depression, and both of them need to be addressed. And addressing these is very important, and it doesn't require medications. If you're not interested in medications, you can also have neurocognitive treatments, such as cognitive behavioral therapy, that can help with anxiety and some forms of attention problems too. But again, speaking with a professional that can tease out whether you have anxiety and or depression and or ADHD would be important. I hope that answers your question. Okay. Another consideration that I always like to speak with, especially with my younger adult patients who are thinking about having kids, or not yet starting to think about having kids, but maybe in the future, is considerations about fertility, contraception. And we spoke earlier about how if you have a child through natural means, that the risk of them having NF is about 50-50. So Dr. Piotrowski, how do you counsel patients about contraception and fertility who have NF1?
We often meet young women and men who are actually most concerned with discussion on family planning. So it's important that they're aware of ways to prevent pregnancy if that is their intent. And if a patient does get pregnant, I suggest referral to a high-risk obstetrician. So NF patients are at greater risk for complications such as gestational hypertension, preeclampsia, intrauterine growth retardation, stroke, preterm labor, cesarean delivery. One of our attendees actually commented that her cutaneous neurofibromas increased during pregnancy, which is very common for cutaneous neurofibromas, as we said, to increase in puberty, pregnancy, and with increased age. So it's important for a high-risk OB to be involved in that care.
Absolutely. And one of the things that I chat with my patients about is in vitro fertilization with pre-implantation diagnosis. And some of the younger kids that I speak with are surprised to learn that there is a way that can help decrease the chance of neurofibromatosis in their children. Can you talk to us a little bit about that?
Typically, we would rely on our reproductive endocrinologists to help with this, but it is true that there can be pre-implantation genetic testing, as well as selection of an embryo for implantation that is not affected by NF.
And sometimes what I like to talk to my patients about is that this is an expensive procedure to harvest eggs, retrieve them, and fertilize them with the sperm of your partner in the lab and test the embryos for which ones have the NF1 pathogenic variants or mutations or not, and then implant back the ones that do not. And so it is expensive. Some insurance companies pay for these treatments. Some insurance companies do not pay for these treatments. But I think it's always a good idea to talk to our patients about that and have them consider this option, even if they have to pay out of pocket, because the care of NF and not only the cost, the monetary cost of NF, but the pain and the suffering of someone with NF that you guys know much better than we do, is something that can potentially be prevented, even if it means paying out of pocket for these kinds of treatments. But again, it's difficult. It's not always available. And a lot of your primary care doctors might not be chatting with you about these options because they're not commonly discussed with the general population. So a pre-genetic counselor could help you discussing this, and prenatal counselors are more common than NF specialists. So if you can find a prenatal counselor in your hospital, your local hospital, they can chat with you about this. Maybe help you with insurance and how to go about doing that. And we spoke briefly about contraceptives earlier, and I mentioned that hormonal contraceptives in women are a little bit controversial, whether using the pills or injectable or implantable devices. Again, I've had many patients who use them without any problems at all, and some patients that feel that maybe their cutaneous neurofibromas have increased a little bit in size or in number after they started hormonal treatments for contraceptives. So I think it's a risk that you have to weigh whether something might increase the number of neurofibromas, and if you want to try that, or use barrier contraceptives like condoms. But in general, they're well tolerated, and in general, they don't cause significant problems. And maybe using an intrauterine device with or without hormones could be a safer choice, maybe. And we don't have enough data to strongly support one option versus the other. Good. And I think there are more considerations to talk about and things that I chat with my patients when I see them in clinic. But as Diana was asking us about earlier, how do we get better answers to the questions we have? And a lot of the things we're saying, Dr. Piotrowski and I, are, we don't know, this is what some people recommend, but not others. And it's very frustrating for patients to hear that. And so the way to know more and treat you better is to do more research. And that goes from basic science research, which means scientists in a lab working with cells and animal models and things like that. And more importantly, the kind of research, or not more importantly, but equally as important, I would say, is the kind of research that includes patients and where we learn from them directly in clinical research. And so we're doing studies to understand the natural history of neurofibromatosis and their many manifestations, the quality of life and how that's affected in people with NF1. We are trying to find better endpoints and patient-reported outcomes. And what that means is when we're trying to start a treatment, we want to measure the success of that treatment. So how do we go about measuring how successful a treatment is or not? And so trying to find ways of measuring the success of treatments is very important. And that's what biomarkers and endpoints and patient-reported outcomes are and how those help. But to get there, we need, unfortunately, patients to volunteer their time and learn about research and help us understand NF better. And research is not for everyone, and we respect, and you should never feel pressured to participate in research, but chat with your doctors to see if there are any clinical trials available in your area. Another good resource is clinicaltrials.gov. It's a website where you can type neurofibromatosis type 1. And I don't know if there are any patients here with neurofibromatosis type 2 here or with schwannomatosis, but there are clinical studies for NF2 and schwannomatosis as well in that website. So clinicaltrials.gov, look at them and see if you wanted to participate. Other organizations like NF Midwest, NF Northwest, CTF, other organizations also advocate for research and have on their websites opportunities for research. So I'll talk to you about a couple of clinical studies that we're working on. One is the natural history of cutaneous neurofibromas. We use this very cool camera system. As I was saying earlier, patient goes into the camera, we take pictures of their whole body and monitor cutaneous neurofibromas over time. And we're trying to learn how those neurofibromas grow and change or not change in some people, but it does in others. We do genetic testing to hopefully learn if there's any mutations that put you at risk of higher number of neurofibromas or not. So if you wanted to participate, you can always reach out to us and we're happy to talk to you. This study is being conducted in Baltimore, but there might be a way for us to pay for travel expenses for you to come and visit with us if needed. So we can stay in touch and communicate with you, see if you're eligible to participate or not. There's another study, and I'll show you a brief video that's about 2 minutes on another research project. I hope you can hear this. Can you guys hear maybe not?
No, we're not hearing it. You know, we did see this earlier. We shared it earlier, and I don't know if we have new people on here or not.
Have you been diagnosed with neurofibromatosis type 1 or NF1 and have one or more cutaneous neurofibromas? Do you want to help improve the lives of others living with NF1? Researchers from Stanford and Johns Hopkins are studying the genes of people 40 and older living with NF1. They want to better understand why some people are more likely to develop certain disorders, like cutaneous neurofibromas. You could have an impact on the future of NF1 care by participating in this research study. You may learn about genetic markers that could impact your health and could be passed down to your children or possibly shared by other family members. Participation is easy. No need to schedule or travel to doctor's appointments. And when you're done, you'll get a $25 Amazon gift card. To participate in the study, you'll need to complete a survey, send us photographs of your skin, and provide a sample of your saliva for genetic testing. You can do all of this in about an hour from the comfort and privacy of your own home. The study is open to residents of the US and select international sites, such as Canada and the EU. Just visit our website at www.nf1genetics.org, complete an eligibility checklist, and sign the consent form to get started. With your help, we may develop new therapies and provide more personalized care, improving the lives of millions of NF1 patients around the world.
So if anyone is interested in participating in research, try to reach out to your doctors and ask for help getting enrolled in clinical studies. Like I said, you should never feel pushed or forced into any research. Research should always be voluntary, and research should not affect your clinical care otherwise. And so, but we're excited about the kind of things we could learn from research. There is another study that I also wanted to talk to you guys about briefly, which is imaging biomarker studies. So at Hopkins, we're trying to understand if those whole body MRIs are helpful or not in detecting the conversion from benign plexiform into a malignant tumor. So, and if you're around the Baltimore area, Baltimore, DC area, Virginia, Delaware, and you're interested in participating, reach out to us and we'll be happy to talk to you about this project. So this is a table summarizing things. There are guidelines, some of which are available to everyone, and they can be shared with their primary care doctors to help them guide the care for your patients, of their patients, including people with NF1. And so physical exams once a year, getting your blood pressure checked at least every 6 months, having your eyes evaluated at least every other year, especially if you're not having any problems, more frequently if you do have problems. We talked about breast screening for breast cancer with mammograms for women. Those kinds of things are summarized in this table. And I think we do have a slide with some final remarks, but again, if you have any questions about any of this, let us know. And Dr. Piotrowski, you had some other comments that you wanted to make?
One of the themes that comes up in my individual discussions with patients and is evident today as well as access to care. It's a major problem. Most NF patients face obstacles attaining comprehensive medical care, and we realize that there is significant financial toxicity that's associated with obtaining diagnostic tests and undergoing treatment. We're working to improve record sharing between institutions because it is essential for your treating neuro-oncologist to see your MRI images, not just the report. The NIH NCI-funded SPORE, which is a specialized program of research excellence, is focused on the RAS pathway, and we're building something called the NF1 glioma dartboard. So this is a unique patient-facing portal that allows for the collection of clinical, pathologic, radiologic data, and we hope that this will yield important insights into tumor mutations and targeted therapies. New and better compounds for NF-associated tumors are needed, but the collaboration and tools required for successful development are certainly growing. We talked about getting connected with an NF center, and I think foundations like NF Midwest are great for education as well. I found it very helpful to click on the NF Midwest website and click on Find NF Care for specific doctors near your home. But if patients have their primary care physician collaborate with the nephrologist that might be far away. That might be a way to access both the latest research and experts who include adult and pediatric neuro-oncologists, surgeons, psychiatrists, radiologists. It's important to work with a team that includes patient navigators and social workers who understand NF patients' unique needs.
Thank you.
I know, Dr. Romo, I know you needed to leave. I told you I wouldn't keep you past.
No, you're fine. You're fine. I was able to work out my schedule so I can stay a little bit longer and answer questions.
Okay, because I think there's a few that we didn't quite get to.
Sure.
A couple of them are a little bit, maybe aren't as part of this discussion, but we'll try to. But I know that there was one about going back to Pheos, was if you had one, what are the chances you get another one?
If you have a pheochromocytoma and it was removed, is there a chance that it could come back?
I guess so. What are the chances you get another one?
It is possible. So you would continue screening, and probably your endocrinologist would measure your hormone levels periodically to make sure that there's nothing coming back. And we always would recommend that you continue to monitor your blood pressure more frequently than the general population. So again, in people with NF1, I always recommend that their blood pressure is checked at least every 6 months. If you've already been diagnosed with that pheochromocytoma, I would probably make sure that you have your own blood pressure machine at home and that you're monitoring your blood pressure on your own much more frequently than every 6 months, even if the pheochromocytoma was treated, to make sure that we don't see any more spikes in your blood pressure, and check your blood hormones periodically. So there is a chance that it could come back if it was resected, but the chances are low.
The other question here is the big one that I think we've tried answering already, is how do you find a doctor who understands? I think that's a huge, huge question. And the NF organizations know this, and I think we're all going to be talking about it a little bit more collaboratively, how we help to improve care. Dr. Piotrowski mentioned you can go to NF Midwest website and we'll tell you, some doctors, but honestly, those are the NFologists, as we're starting to call them. So it's not, it's still not places people can go. We try to collect information in the background. If you have a family practitioner or somebody you're going to, you can give that to us, and we can try and refer some patients. I think when you find a empathetic doctor who's listening to you and willing to learn a little bit, we certainly like to share that and get people to go to them. But how do you find a doctor who understands? It's hard, and we hear it all the time. So we know it's hard. We know, people are going and they're saying they're in pain, and doctors are still telling people that, oh, there is no pain in NF. We have had situations where people have had a lot of pain and they keep saying there's pain, and then they don't get that PET scan and they have an MPNST. So it is a problem. We just have to really, really educate yourself and be patient with your doctor, bring in the care guidelines, see if I don't know if doctors, like your family practitioner, your internist, will they reach out to an nephrologist? Is an nephrologist able to consult?
They can. I think they can. I've received emails from people that I don't know in the medical field asking specific questions. And we do have patients at Hopkins and at MSK that come from other states, from out of state, for their care here. But it's not practical for them to be visiting with us every 2 months or 3 months. And so what I typically say is provide me with the fax number or the phone number to your primary care provider or your local team, and I will send my notes. And my notes from your clinic visits will include all my recommendations for everything NF related. And so I don't need to be the one monitoring your blood pressure. You don't need to be an nephrologist to do that. But your primary care doctor can do that. They just need to know to do it.
But what if they never got to you? They can't even get to you. They're just out in the general public, and they're not able to get to an nephrologist, and they have, some weird thing that is obviously related to NF. And I mean, and adults have, you know, there's the problem of distance, that there's nothing nearby. There's the problem of they don't have their mom or their dad or their parents making them go like they had when they were children. They have to, you know, they don't have that support system, and they don't have, you know, they have jobs. There's just a whole host of, they put themselves last. So there's a whole host of reasons why adults don't get in. So in the meantime, I think education and, you know.
And another thing that could be considered is that I believe there are a few more pediatric nephrologists than there are adult nephrologists. And so if that's a word that you coined, Diana, I don't call myself an nephrologist.
Dr. Piotrowski used it, and I know, I think Dr. Lister may have coined it. I'm not sure who coined it, but somebody, one of the NF doctors did coin it. I used to call him the NF quarterback, the NF primary doctor, or the quarterback for your NF.
Yeah. So, but I think there are a few more providers that focus on children, and sometimes, they understand that there's a huge lack of adult providers, and so they will keep seeing adult patients that had established care in their clinic when they were children. It is very difficult for them to accept new adult patients, but some people can, especially if they're 24 years of age or younger. And so trying to consult with even a pediatric NF specialist might be an option, because you might have one closer to you than you think, and checking the websites and see who they are and where they might be is important. But you're absolutely right. And unfortunately, our NF patients have to become their best advocates and get educated and attend these kinds of meetings to learn about the things that they should be thinking of, and asking their physicians and educating their physicians about the things that they need help with.
To build on something you said earlier too, when you were talking about pain, and you know, that something may take a while and you may have to come back, or you may have to change. I think that's the other thing that would help, that helps. Personally, I don't think people should be quick to jump to another physician because they're frustrated. As somebody told me, every time you jump to another physician, they're basically starting over with you and having to learn everything new. So I think unless your primary or the neurologist or whoever you're going to there's a personality conflict, or you just feel they're just really, really not listening to you, I don't think it helps to be jumping around. I think if you have pain and it's not working and you can go into somebody else, you're just starting over, and you're better off going to try to continue with that physician if you can. Does that make sense? So if they don't understand, just keep going to make them understand. There you go, I guess.
Yeah, no, and it's also a safety concern, especially if you have multiple providers prescribing several different medications. If they're not aware of what the other one's prescribing, you might be in a situation. I saw a patient not too long ago who was taking the same medication, but with different names, with different brand names at the same time. And one came from one provider and the other came from another provider. So both were prescribing the same medication, but she hadn't noticed it because the names on the bottles the brand names was different. And so she was at a high risk of overdosing from this medication if she had taken it at the same time. So having multiple providers managing the same problem is always a risky situation.
Makes sense. The other question is about SSI and SSDI and mental health issues. I think you talked a little bit about the mental health issues. I did want to ask you one thing regarding, I guess, mental health. Is it came up, or physical brain health. It came up last night in our social. Do we see more dementia in people with NF1? Is there any study of that?
Not to my knowledge.
More common thing. No?
Not to my knowledge, but I wouldn't be surprised if there was a link with higher incidence of dementia or prevalence of dementia. I don't know if Dr. Piotrowski has heard about dementia being more
somebody said
common.
there was a study from Norway that just came out.
Maybe.
I think it's certainly possible, because we do know that there is a cognitive impairment that's associated with NF1, and that could include certain types of memory loss. When we say Alzheimer's dementia, we mean that there isn't another cause for the memory loss and that it's an elderly patient who has trouble with their activities of daily living. And we see many reasons for this type of difficulty for NF patients.
So regarding the SSDI question, we do have a webinar that was recorded on that. So whoever the anonymous attendee is, if you want to reach out to me, I can link you to that. I think the general answer to that is you could be eligible for SSI, SSDI, not because you have NF1, but if you have something that makes you eligible that has created a disability, such as cancer. My daughter is on disability, but she has, a lot of tumors and issues that have caused that. So if you have physical issues from NF, you can apply for SSI, SSDI. But and then I don't know, are there any more questions or anything in this chat here? Want to make sure we're getting through them all. I think somebody had a question from 1 o'clock, so it really shouldn't fall on you, but I feel so bad leaving anything unsaid here. But they were referring back to the new diagnostic criteria. What's meant by pathogenic indicator, I guess, was number 8 on the new diagnostic criteria. We probably don't have to answer that, but if you happen to know the answer.
So like I said, yeah, so there's a new diagnostic criteria for NF1 that includes the use of genetic testing, whereas before genetic testing was not part of the criteria. It is now something that we can rely on to help us make the diagnosis, but it's still not required.
So that's what's meant by a pathogenic indicator is genetic testing?
So when I spoke earlier about genetic testing, I mentioned that a genetic counselor can help you with the potential answers to genetic or the potential results of genetic testing. And so when someone gets a genetic test done, you can have 3 potential answers. One is that you have what we call a pathogenic variant, which means that test is positive, basically. That you can have a test that's negative, and your counselor would talk to you about what it means to have a negative test. Does that mean that you rule out NF completely or not? And in some cases, the answer is no, especially in more complex forms of NF like mosaic NF, somatic mosaic NF, where not all the cells in the body are affected by neurofibromatosis. And in those cases, people who have NF, the syndrome, might have a negative genetic test. Again, your genetic counselor could talk to you about what those tests mean. And the third option is that you have a variant of undetermined or unknown significance, or a VUS or VUS. And what that means is that a mutation, it was found in the NF1 gene, but that mutation might not necessarily mean that you will develop neurofibromatosis. And so again, talking to your genetic counselor or your NF specialist would help you understand the results of your genetic testing, whether it's a pathogenic variant or not, if it's a variant that we don't understand how it works, or if it's a negative test. But they would be able to tell you if it's a pathogenic variant, which means it's a variant that we know affects the formation of the protein that's made by the NF1 gene. So the NF1 gene makes a protein, and if it's healthy, that protein works and you don't have NF1. If it's unhealthy and that protein is not working, you can develop the NF1 syndrome, and that would be a pathogenic mutation or a pathogenic variant.
Thank you. So I think we're going to end with this last question. Will these sessions be recorded? We did record them. I think I told most of our presenters I'd come back and make sure you're all okay with it, but I don't know if you both are okay with this being shared as it is. I don't think there was anything we had to worry about. So we will get those published. It might take us a little bit to get those up. They want to know if they have any questions that they can contact you. I don't know if you want to share your emails, but you can certainly contact us and we will try to forward a question or get it answered. That might be the easiest way to do that, if that's all right.
Yeah.
You guys had some studies, so send me your links to your studies and we'll put those on the website too, in case anybody is looking for them. I think there was somebody earlier that had asked about the gel study, and I think the ones you have, I'm sure people are going to be interested in that. So if you have direct links or more information, Yeah, and we're going to get you guys to 1,000 on the, we're going to try hard to get to that 1,000 on that genome. We have a magic number.
It is an exciting project. And again, I think that the benefit is that we'll learn more about cutaneous neurofibromas, and eventually that data set, that information that we collect could help us not only learn about cutaneous neurofibromas, but also that same data set could help us learn about plexiform neurofibromas, cognitive problems, depression, and anxiety. So I think it's an incredibly interesting project, but we need a lot of patients to help us answer the questions that we have. A small number of patients will not give us the answers that we're looking for.
Well, I noticed in the cartoon they didn't mention that you get your genetic information. I think that's a fascinating part of it too.
You get to have the report of the genetic testing. The genetic testing for that particular project is not CLIA certified, and what that means is that if a mutation or a pathogenic variant is found, that you would probably need additional testing to confirm if it's an actual mutation or not.
Okay, but it gives you some heads up.
Exactly. So the test that we're using, when you go to a lab and get tests done, they are certified by an organism that makes sure that it's the best study that you can get. And in this particular case, we're not CLIA certified, but if we find something, we can help you get to a CLIA certified test to confirm or rule out what we found in our testing.
Okay, well, I think we're good. We went a little bit past time. We made it through the day. We thank you guys for participating. This has been very interesting, and I like this format of going through a patient and kind of, there's still a lot probably to be covered, but send us your questions and we'll see if we can get them answered. Thank you both for coming, and have a nice night. I think you're both in cold weather like we are, so enjoy yourself.
Thank you.
Thank you for inviting us. Thank you, Dr. Romo, and thank you for hosting this fantastic event. The NF patients face many difficulties and somehow manage to smile through it all, and it's very inspiring. So thank you for all the work that you do.
All right, thank you. Have a nice night.
Thanks, everyone. Thanks for your questions too.